Hello, my name is Ian Roberts. I am the Head of Programme in Improvement Cymru, and it gives me great pleasure this afternoon to be having a conversation with a good friend of ours, Dr. Roger Resar, who joins me from the United States. Some of you will be familiar with Roger, who's been helping support us with some of our work relating to real-time demand capacity, which is what we're going to talk about today. But some of you may also have come across Roger through your studies around improvement science and looking at different pieces of research that are available. And Roger is a well-respected author of a number of different facets of improvement. And Roger also very kindly hosted a presentation for us at the recent Improvement Cymru conference earlier on this year around reliability theory. And Roger has very kindly given some time this afternoon for us to have we've labelled it a masterclass, but to have a really good in-depth conversation this afternoon about flow and the science of flow and real-time demand capacity and where some of that comes from. And I'm going to be spending some time with him this afternoon to pick his brain and gather some of that rich learning and experience that we can hopefully use to support us here in Wales around our work for improving flow. Thank you so much for making the time to join us this afternoon. Lots of people will be listening in with keen interest to our conversation. I wanted to ask if you wouldn't mind just sort of starting a little bit, just so we can learn a bit about you and your background to improvement. I know that you're a clinician by background. Would you tell us a little bit about your biography and perhaps how you've got involved or so involved to become an internationally renowned expert on improvement science? I wonder if you could just tell us a little bit about that journey and your background.
You make me sound pretty important with this international presentation, but I'm a physician. I was trained as a pulmonologist, critical care physician, and about 20 years ago, I started a journey with quality improvement work. My clinical work was done at Mayo Clinic, and I was heavily involved in the ICU and started to see big deficiencies in how they did things, and gradually became more and more interested in quality improvement, and eventually actually joined the Institute for Healthcare Improvement and worked there for approximately 10 years on various aspects of quality improvement related to safety, critical care work, flow, in those arenas. And I am now a senior fellow at the Institute for Healthcare Improvement. About 15 years ago, I started our journey on flow. And in those days, our rudimentary thinking had to do with certainly if we could improve what happens in the A&E, or if we could improve what happens in the surgical suite, or perhaps how things moved out of the intensive care unit, we certainly could improve flow in hospitals. And I and my colleagues spent a lot of time and years advocating for projects that would improve portions of the hospital, whether it was a project to move patients out of the intensive care unit, a project to shorten hospital days for a given diagnosis, or perhaps somehow improve the discharge process to long-term care facilities. I think you get the picture. We worked on a lot of different aspects of hospital care, much to our disappointment. We found that although flow might be classified as improved in a certain portion of the hospital, there was never any evidence of increased throughput. And what I mean by that is, with the same resources, being able to see more patients in the same period of time. that was very disappointing to us because a lot of hard work had been put into these, and we call them large projects. This hard work was emphasized primarily as a flow for hospital improvement methodology, but it never had its effect on throughput. And hence, real-time demand capacity was born. It emerged because we realized that all these inefficiencies that we see in a given hospital on a given day, all these inefficiencies were not being addressed in any way at all. We might have finished a wonderful project in the A&E, able to move patients out quicker, maybe able to see patients quicker in the A&E, and there might have been effects on ambulance waiting or something like that. But at the end of the day, oftentimes we found that the opportunity for improvement in the A&E oftentimes was at the expense of somewhere else in the hospital, where a ward might have been asked, we're going to have one patient in the hallway where we can take care of them so we can relieve the A&E of some of the pressure. Well, a great idea, and it has some functionality. But again, you optimize one part of the system at the expense of another part of the system. So what RTDC, real-time demand capacity, does, as we developed it over the last 10 years, was to admit that there were many inefficiencies going on a daily basis in a hospital, and that we needed to have a system that looked at these inefficiencies and on any given day made those inefficiencies visible and made those inefficiencies able to be changed or improved or dealt with in some way, so that at the end of the day, the throughput for that day was better than it was before you had this kind of opportunity to visualize these inefficiencies. So that's how I got to where we are in. And I'm pleased to say that we have accomplished the fact that throughput can now be measured and seen in organizations without added resources of staffing, beds, or what you might otherwise need, and see more patients be admitted and discharged in a given period of time in a given hospital. And I believe, after all, that anyone who works on, quote, flow really wants to work on throughput and really wants to see more patients in the right patient for the right bed at the right time, but we want to do more of that with the same resources that we have, without making it undue difficult for those staff and wards that are working in this arena. So that takes us up to the present time, Iain.
And that's really helpful, Roger. As you were speaking, there were a few questions that came into my head, really, which is I'm just interested for you as a senior clinician, and just thinking about that importance of flow, because we often talk about flow and throughput, but marrying that up with quality and safety and barriers to flow being an issue of patient safety. And I just wondered if you could just say a little bit about that in terms of the relationship between flow and patient safety, and your views and opinions on that. That would be really helpful.
Sure. I think that anyone who has worked in a healthcare facility where you have stress in a way that creates people to have to work faster and harder than they need to work, puts patients at risk. One of the things that we talk about in our work is, to the extent possible, we want to get the patient in the right bed at the right time for the right diagnosis. And when you have a patient on a ward that is what we call an outlier ward, that is not for the patient's best safety in any way, shape, or form. And when you have a patient with pneumonia on a orthopedic ward, I think all of us would say, you know, that's not probably the best place for that patient. And yet, if you look at your own organizations, the number of patients that are outliers on wards are significant. In the United States, we used to say, and I'm not sure what it is right now because I haven't done clinical work for a couple of years, but we used to say that our goal was to have outliers on wards under 10%. That would be our goal, which meant that you would have outliers in the 15 to 20% range in a given hospital on a given day. This is not promoting safety as far as I'm concerned. And as far as the evidence is that patients do better on units where their care is the usual care rather than the unusual care. And so, yes, safety is a big factor, and this is one of the things that should drive us to look at these inefficiencies that are in the hospital and try to take every opportunity to visualize them and then do something about them.
So, Roger, one of the things that we often talk about in improvement is to focus on a project that is in your realm of control. Often something nearby that you can influence quite a lot. And it often feels unintuitive, I suppose, to us who've been doing improvement for a little while to suddenly take a step back and go to the level of the system. And you described there, lots of projects, but may not benefit different parts of the system. What was that like initially for you as a senior clinician in your organisation, influencing your colleagues in that space?
To be honest with you, it was frustrating. Frustrating then and now. If you look at most of the flow work that is going on around the world right now, there is an advocacy for large projects. And please do not misunderstand me. I think every one of these large projects can have tremendous value for a hospital. But in our experience, these large projects need to be committed to only after you've taken as many of the inefficiencies out of the system that we experience on a daily basis. One of the things that one of my colleagues often says is that hospitals today are dying from 1,000 cuts rather than 1 or 2 fell swoops of a sword. And if one could possibly take 1 or 2 large projects and think that they are going to solve all of the problems that the inefficiencies bring us in the hospital, I think we're having a dream. And so our approach now is to say, let's give you the tools to visualize and work on inefficiencies on a daily basis throughout the hospital, not just in the A&E, not just in the laboratory, not just on discharge, but rather throughout the hospital. And then, and only then, look at the landscape that your hospital is in after you put these real-time demand capacity methodologies in place. Then look at the landscape and say, you know what? I think we need to work on a project in the A&E, or I think we need to work on a project in the critical care unit. Because these projects are extremely valuable. But I think what's happening is organizations are putting them in before they do the real-time demand capacity and not getting the bang for the buck that they need in terms of throughput.
So, Roger, I would completely agree with you. I'm mindful that there are lots of our colleagues across the world, not just in Wales, who are working incredibly hard to support patient flow, and I know some of them very closely, who are working incredibly hard. One reflection that I have, I'd be interested in your view on it, is that often we have our colleagues who are working really, really hard, but they are nurses, doctors, managers, who have never actually been taught, if you like, the science of managing the queue. And one of the things that I picked up working with you and Kevin and other colleagues from RTDC advisors is this notion of queue theory. There's underpinning RTDC, there is a lot of science there. We don't necessarily need to teach people about that, but could you say something about moving from the kind of intuitive, this is how I think we need to deal with the pressures that are in front of us now, to the science of the queue, and any thoughts on that?
Sure. As we look at real-time demand capacity, what we emphasize is this is a science-based methodology, based on science that has been used in industry and in work outside of healthcare for decades now. And one of the scientific legs for real-time demand capacity is understanding queue theory. And without going into a lot of detail, Ian, the queue theory says when you have a system where demand is greater than capacity and your utilization is very high for that particular service, let's say 99% or in that vicinity, what queuing theory tells us is that because of the shape of the curve, it's a logarithmic curve, very small changes will have a much larger effect on the number of people waiting than you would ever think. And this has been borne out and proven scientifically for decades now. And going back to the concept of these small inefficiencies that I was telling you about earlier, the reason we focus on these small inefficiencies is because these small inefficiencies, when dealt with on an hourly or even a daily basis, are the small changes that we observe on the curve that has a significantly larger effect on the number of people waiting. So one could say, gee, if you're just dealing with these little inefficiencies, how can you possibly increase throughput? You increase it because of the science of the queuing theory And the shape of the curve as you increase your utilization from, let's say, 60% up to 99%, the shape of that curve is logarithmic. Very small changes can have that big effect on weighting. And we have seen this happen in a lot of different industries, not just what we're doing with real-time demand capacity. It's the ability to take what's proven somewhere else and that scientific knowledge, bringing it into healthcare, is what's going to make our systems better. The idea that somehow we're going to invent some new science in healthcare that's going to change how we deal with patients, I think, is futile. But looking at industry and how they've done it, and then bringing that into healthcare, that's what we've done with real-time demand capacity, and understanding queuing theory and understanding how those small inefficiencies, when you work on them, affect the number of people waiting. That is one of the key principles that we teach with real-time demand capacity. And this is not rocket science. This is pretty straightforward, dependable work that's been done for decades prior to introducing it to healthcare.
I'm really interested when you're talking about rocket science and helping the whole system to understand the part they play. I think there's a few observations there. One is that sometimes when you go into a hospital, that it can sometimes see that A&E is very, very busy, and the rest of the hospital is working at a different level of pace. And then when you talked about rocket science, I was thinking about how RTDC surfaces some of these things, and it reminded me of the famous story about Kennedy visiting NASA and talking to the cleaner, and the cleaner said, when he asked him, "What do you do here?" he says, "I help put men on the moon." And it's kind of recognizing that within our system, potentially all of us are doing something that can help with the flow of the patient care, and sometimes helping people to understand that in the system, I think, is actually quite a powerful thing to do if you're not directly connected. So that's just my reflection on some of the things that you were saying there, Roger.
If I could interrupt, let me tell you, let me enrich this with a story. This happened in one of the actual hospitals in Wales that we were working with in the last several months. And in this particular hospital, blood drawing for laboratories is done on a very regimented schedule, as it is in many hospitals. And one of the patients that could have been discharged that day, if they could get that blood draw done at a unscheduled time. And what this particular hospital did was say, we're going to allow, let's say, 4 unscheduled blood draws a day. We'll just allow that. That'll be part of our system. Well, by doing that, even though that lab person who draws the blood probably has very little in their mind to do with the patient actually being discharged from the hospital, okay? They're more focused on what the laboratory is doing. But by having that blood draw done early on an unscheduled time, in that particular hospital, on that particular day, 2 patients were allowed or able to go home earlier in the day than otherwise would have been anticipated. Now, that's just a very small example, but it's an example of an inefficiency that was handled in a very concrete way by someone who probably thinks they have very little to do with the discharge of a patient. You know, the discharge of a patient has to do with the clinician writing orders. It has to do with physical therapy doing something, not me in the laboratory. So Your point is very well taken in your story about Kennedy going to Nassau, and that everybody needs to realize that you have a part in this. It's a system. And when we make available in this system, as you see it, what you can do for the eventual outcome, as this lab person can now see, that then makes for the entire enterprise to be better able to deal with this series of inefficiencies that might occur that eventually will go back to the science of the queuing curve, because we've changed something small and now it has a much out of proportion effect on the number of people waiting. So sorry to interrupt, but I
No,
wanted to relate that story because I thought it was a pretty, and by the way, this was nothing that the clinicians came up with. This was nothing that a safety committee came up with. This came out of the laboratory personnel themselves, who said, yeah, we can get an on-scheduled blood draw today. And by the way, why don't we just set this up to happen every day, that will allow 4 of them? And to me, it's just a beautiful way of showing how everyone has a part in what we're doing.
So, Roger, we spent a little while now just sort of talking around the theory of it, learning something about you and how you've been drawn to this and the science of flow. I just wondered now if we could sort of maybe start to help some of the uninitiated on the call to start thinking about the cycle of real-time demand capacity, this 24-hour cycle, because as all clinical colleagues on the call will well know, discharging people isn't a straightforward and easy task. It doesn't just happen like this. There's planning and actions involved, and I wondered if you could sort of start to take us through this cycle of thinking about tomorrow,
Sure.
think about tomorrow today.
Well, the cycle actually is the formation of the and the use of 2 additional principles. And one of the principles is the idea of prediction. And what we do is we set up a system that's extremely simple. It's called the R sheet, and it's called the R sheet because R stands for responsibility. And mid-afternoon, let's say 2 o'clock, 3 o'clock, every ward sits down with 1 or 2 persons, and they say, who do you think might be able to go home tomorrow before 2 o'clock? And we say, you don't have to be sure of this. You have to have about a 50% chance that the patient will be discharged before 2 o'clock. But if that patient is going to be discharged before 2 o'clock, what needs to be done? What would we really need to be done? Would we need to make sure physical therapy gets in here? Do we need to have a diabetic teaching going on? Do we need to get pulmonary function tests? What x-rays need to be done? All of these sorts of things. Now, the important piece about this is that this is not the clinician doing it. It's not the doctor. It's the nurse that's taking care of the patient, and perhaps one of her colleagues, maybe the ward sister or someone else, where they go over the patients on the ward and they say, you know what? These 3 patients have a 50% chance of going home tomorrow. And in order for this 50% to actually be realized and change to, let's say, 100% at some time, we would need to do these 3 things. Okay? Now, that's what we call prediction. Now, I got to tell you a story. This has to do, and I'm sure you've all eaten at McDonald's sometime in your life. Well, McDonald's in many parts of the world, particularly in parts of the world where there are a lot of cars and you're driving up to the window to get your service, use something called hyperactive Bob. And what it is, it's a camera that they put out by the place where you do your ordering for whatever you want to get at McDonald's. And what it does is it predicts what you might order. So I'll give you an example. If you had a car that was a van, for example, filled with kids, well, you might predict that you're going to order some kids' meals. If you have a van with, or a car with 4 adults, you get a Big Mac and some cheeseburgers. All right. And this might sound really, really simple to you folks, but it has a lot of depth to it. Because what McDonald's is trying to do is they're trying to say, you know what? If we can save a few minutes on how long someone has to wait to get their food, we basically can have more throughput with the same staff and the same number of ovens and whatever we have, okay? Just like in a hospital. And they've been able to show that they can deal with and get more meals out over a lunchtime. And people wait a shorter period of time when they go ahead and predict. Now, the prediction does not have to be 100% accurate. Their prediction has to be somewhere around 60 to 70% accurate. And that will give them the efficiencies that they need. Well, we've taken that principle and moved it over to the hospital, and we said, you know, when we ask you to predict discharges, what we want you to do is not be 100% sure they're going to go home, but if they're, 50% chance in the afternoon before the next day, 80% chance the next morning, that's good enough. And by predicting these discharges, what we also ask you to do is list what needs to be done in order to accomplish this. And marrying those ideas, that is what needs to be done, to your prediction, what we found out is that people can do a pretty good job of predicting what's going to go home that next day. In fact, in a given organization, we only expect 60 to 70% accuracy. We do not really expect more than that. In fact, if you've got 100% accuracy, we suggest that you are not doing a very good job at all, because those are only the sure things. You're not taking advantage of the fact that, well, maybe this person's got an 80% chance of going home. And if we do get them home, that's a bonus. But if we don't, nothing lost, okay? And it brings in the third principle that I want to talk about before we go on to any other questions. And that third principle is the idea of why are we focused in on, and you heard me mention about 8 in the morning until 2 in the afternoon. Why are we focused in on getting patients out before 2 in the afternoon? And it goes back to work done by a University of Michigan professor where he studied traffic jams. And what he studied on traffic jams is that the vast majority of traffic problems occur not because of an accident and not because of road construction, but rather because of the variation in braking and speeding up of cars, when there might be a slight interference, like the bright sunlight, or maybe there's a car in the other lane where there's an accident, or maybe the policeman is coming with a siren in the other direction or something like that. And this variation in braking and speeding up leads to a kind of a traffic jam that occurs all the way back to however long the traffic jam actually is. And what this professor has found out is if he puts adaptive cruise control on 25% of the cars, and adaptive cruise control takes the variation of braking and speeding up out of the picture because you keep that constant distance between the car in front of you. What we've done is adapted this theory and this principle to healthcare. And what we do is we say, okay, our adaptive cruise control is going to be between 8 in the morning and 2 in the afternoon. And what we're going to do is we are going to predict everything that we can that's going to happen between 8 in the morning and 2 in the afternoon in terms of admissions and in terms of discharges. This is where the term real-time demand capacity actually comes from. In real time, we are going to adjust what needs to be done to make that time between 8 in the morning and 2 in the afternoon as good as we can get it. Just like in the work done with the traffic jam, it's not perfect, but as good as adaptive cruise control can do. What we're going to do then is apply this to the hospital, and when we have done this, applied these three principles, and I've gone through the principles very quickly, I understand, but when we've applied these three principles to the hospitals that we've worked with, we've had marked improvement in throughput. And just as you don't have the traffic jam because you worked on adaptive cruise control, in the hospital, we don't have that traffic jam that occurs late afternoon, early evening when patients are trying to be discharged at the same time that they're trying to be admitted to the hospital. And we all have experienced that. So the fact that we can affect throughput, and I'm not minimizing the fact that our effort is on throughput. What I want to do is share with you, for example, one large hospital in our country over a 6-month period of time with no additional staff, no additional beds, applying these three principles had 700 more admissions in that same period of time over a 6-month period. That's pretty impressive. That means that you're taking inefficiencies out of your system, you're modulating them, and then you're allowing more people to be taken care of. And then it goes back to your first question. What does it mean? It means you get the right patient in the right bed at the right time. And that's what we're accomplishing. Now I'm going to make a statement here, and I don't want to maximize it, but I want to make sure that everybody understands that the vast majority of this work, not all of it, but a lot of this work is not put on the shoulders of the clinician. It's put on everyone who's working in the hospital to take out these inefficiencies, from the person who's drawing the blood from the lab, to the physical therapist, to the pharmacist planning the discharge medications, to the social worker arranging long-term care, to the physician who understands that a prediction might have been made on their patient and that maybe today he's going to have to write orders a little earlier than he did yesterday for a discharge. But the vast majority of this work is not on the clinician's shoulders. And this has the responsibility being placed on everyone, not just on a portion of the staff in a hospital. So often it's been my experience that the improvement projects make a segment of the staff wholly responsible for doing something, and it puts a lot of additional stress and pressure on them. RTDC does not do that. What it does is it spreads this out to everyone and says, look, we want to help you take the inefficiencies out of your daily work, not put more work on your shoulders. So hopefully I've had a chance to share with you what the three principles are and how they interact and why we call it real-time demand capacity.
I wonder if I could just take you back to prediction, Roger, and just to qualify a couple of points, really. I think we find ourselves in an extraordinary situation here, sort of post-COVID. Certainly the status in the UK at the moment is staff feeling really overwhelmed, can't do much more. People, have gone over and above, and there's a level of exhaustion in the system. And when we talk about predicting and trying to create more throughput, it's almost like we're trying to put even more on their shoulders. But I wonder if you could say something about the fact that I think when we're in the space, it's actually there's an awful lot of clinical managerial nursing time that's actually taken trying to make the system work to enable a discharge. And actually, if you took that away, you get the throughput because the system was actually working. So it's not about putting more on people's shoulders, it's actually making that bit easier to enable the throughput to come through. Is that right, if I understand that correctly? Because I think there's an awful lot of clinical time just to chase a bed, chase bloods, all these kind of things. I just wonder if you could say a bit about that as part of prediction and helping minimize that variation.
I think that you've, I think, expressed it really quite well. And the experience that we've had is that when you allow the staff to identify what the inefficiencies are, and then to allow the staff to act on those inefficiencies the way they want to act on them, what you're going to see is you're going to see significant improvement in throughput, because most individuals, when they look at the current way they do their work, what they'll say is they'll say, I know it's crappy, but that's just the way we got to live with it. That's just the way it is. That's just a part of doing my work. What we want to tell people with real-time demand capacity is when you identify one of these inefficiencies, and if you can talk to someone and you say, if you could help me out with this today, could we get an unavoidable blood draw today, or an unscheduled blood draw today? That would really help me out a lot. Now, what we find out is that when people talk to each other and solve these problems real time, not next month, not next week, but real time. Real time says, could you draw a blood today at 8 o'clock? I know it's not scheduled. That's talking to another human being. And the idea is that when everyone does this, everyone gets to help each other in one way or another. And when that happens, you take stress out of the system. You take that work that people are doing that they say, you know what, I've just got to do it. That's the way it is. I know it. When you start taking all of those out of the system, that's when people, even in the post-COVID times, will say, you know what, my life is better now. Let me give you a little insight. We have done real-time demand capacity in hospitals in the US and hospitals in Europe. We do not know of one hospital that has given up real-time demand capacity. Now, they may have tweaked it a little bit to make it work for them a little bit better, but the three principles are still there. They predict, they have a portion of a day that they try to make perfect, and they understand that if they take the small inefficiencies out, that fewer people are going to be waiting on the other side of the line. And I think when you use science like that, what happens is people will see the benefits very early on. And it might be, I don't know, if you might comment on some of the organizations that have played with this in Wales over the last 6 months and what some of the responses of the staff are to real-time demand capacity.
Definitely one of the things that we're going to do is start testing that out and start exploring the stuff to triangulate and get some qualitative data to accompany some of the quantitative aspects, so that we're learning with them and they're able to inform the system. That's one of the things that we want to explore. Roger, I've got one more question for you, because I think what you've really described for us there is an awful lot about culture. And one of the things that we're looking at is the IHI safe, reliable and effective care description of culture and the system, etc., and all of that. But the one thing we haven't discussed in this is leadership. And I just wonder if you could just say something about what do the leaders need to do to help this to flourish within our system, to create those conditions?
That's an absolutely critical question. And one of the things that we do as a team when we start working with a hospital is we talk to the leadership and we say, here are some expectations. So let me talk about that a little bit. We need to see someone on the senior team that has as, or will be given as part of their responsibility, the flow and throughput of the hospital, so that real-time demand capacity, RTDC, gets taken under that person's wing at the leadership level. And so we look for that person, number one. Number two, we look at each ward, and on each ward, we need to have the leadership of the ward manager or the sister on the ward, and expect them to understand the 3 principles that we've talked about on real-time demand capacity and why we're doing this. So we need that leadership on every ward. We need to have at least one person in the organization, usually more than one, but to start with one, whose main responsibility is flow in the hospital. Now, this is different than the leadership person. The leadership person is the person who's going to make sure that the rest of this happens. But this is a person that in our country affectionately is known as the flow czar. And you have people like that in your hospitals, I know. These are the people that go around with clipboards and they know who's in the A&E and who needs to be moved from Ward A to Ward B because they don't belong there, who needs to go to X, Y, and Z. So you have these people. We're asking that that person become solely responsible for the interactions of what's going to happen in RTDC. And the main interaction that's going to happen, the big one, is going to be a mandatory bed meeting every morning around 8:30. That mandatory bed meeting lasts 20 minutes. The senior leadership person is the person that makes that happen. That is going to be a meeting that surpasses all other meetings at 8:30 in the morning. The flow manager person is going to run that meeting. And at that meeting, that's where people talk. That's where people show what is my demand for my ward today, what is the capacity currently, and how many patients are going to be discharged by 2 o'clock, and what is our plan going to be to make everything hunky-dory during that period of time. So that person also then has the responsibility of going back to the wards later in the afternoon and saying, Was your prediction accurate? Collecting some data. That person also may be responsible during the day to facilitate plans of what we're going to do to get patient X, Y, or Z home before 2 o'clock. So when I talk to leadership, that's what I mean about leadership. Senior leadership, board level leadership, acceptance of a real-time demand capacity, and that singular person, that flow capacity person that's going to run the bed meeting, that's going to be responsible for collecting some of the data.
Excellent. And I think the way we've kind of encapsulated that in Wales at the moment, Roger, is to call it situational awareness. That
Of course.
awareness from the board to the floor, to the floor, to the board, of understanding what's in the system. Roger, I've asked you a lot of questions. We didn't send you a script about what questions we were going to ask you, but you've responded brilliantly to all of them. So you got the job. I think it's been great to talk with you, and it's really helpful to explore some of these concepts, the 3 principles of RTDC. And there's lots in there, and I think there's lots that people can think about it. But I think what is really powerful is that you described or translated quite complicated improvement science methodologies, methodologies of science, etc., queuing theory, etc., which are really complicated, and people spend a lot of time at university exploring that, into something that is tangible, that people who are trained to be clinicians and nurses, doctors, etc., that's what we want them to do. But here's a simple methodology that will really add value to them, without necessarily having to go off and learn all these complex theories, because that's not what we want you to do. We want you to be looking after patients, and to feel that you haven't got barriers in your way to do that, is how I take it. Any final messages for us this afternoon, Roger?
Sure. What I would emphasize is, even though some of this stuff might sound somewhat complicated to you, our experience is that this is readily undertaken by your staff. This is something that is not difficult, it's not time consuming, and it will, in the long run, make their lives and the work that they do and the patients that they take care of far easier than what it currently is. And it's just using basic principles in an organized way, so that you can take advantage of what I find staff people say, you know what, it's just what I have to do to get through my day. And when you hear people saying that, you have to be thinking, what can I do to take that off their shoulders? And that's what real-time demand capacity does. It allows these folks to get the right patient in the right bed at the right time for the best care in the shortest period of time, with the least amount of resources that need to be used for that particular arena of work. So I want to thank you, Iain. I want to thank John, who wasn't able to be with us today, and Adam and the rest of your team. We have truly enjoyed working with you folks and have seen the dedication that has gone into this work from your side. It's not always been easy. We use different terms. we don't use A&E, we don't use wards. We have all kinds of different terms, and we've waded through a lot of thicket, but I think that in the long run, we've had a wonderful experience. I want to thank you for the interest in real-time demand capacity, and hope that we can work more in the future.